We are live now. With all your permission, I'm starting this session for today.
Sure. Please, go ahead.
Good evening, everyone present here. I welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Vijay Barat, sir. And let me share some of the achievement of sir. Sir has done MBBS, MD, consultant allergist, pediatric pulmonologist, clinical immunologist, and consultant at Sai Allergy Asthma Eye Hospital, Shayadri Hospital, Imandar Multi-Speciality Hospital. And today, sir is going to speak on a topic advances in tuberculosis on the occasion of World Tuberculosis Day. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Yeah, thanks Paras for the kind introduction, and thanks to IJCP for giving the platform on such a very important topic, the tuberculosis. And while celebrating the World Tuberculosis Day, I still remember since last 34 years when I joined my MBBS in JJ Group of Hospital, Grand Medical College. And we used to see a lot of patients in tuberculosis wards. And even we used to be scared to go nearby those wards or because patients used to be there. And even amongst our colleagues, we have seen many colleagues suffering with multi-drug resistant tuberculosis. I remember when I was doing my MD in Wadia group of hospitals. I was in Cooper Hospital, where I found one of my colleagues. She had a multi-drug resistant tuberculosis, and her quality of life was suffered so much. And when I joined my MD under like my the unit in charge, Dr. PM Mudani, like who was known as a father of pediatric tuberculosis, and when along with him, we saw, I mean, each and every part tuberculosis patients. So it can involve any part of the body, even the lacrimal gland tuberculosis, when the otitis with tuberculosis. So many cases, every gland, every part of the organ, skin tuberculosis and all, ocular tuberculosis, because he was very well known and he used to have patients from UAE and outside also for the diagnosis and all. So this is still after 34 years, we are seeing that the tuberculosis has not gone out of India. I mean, we cannot eradicate the tuberculosis. So there are multiple factors for that. And so as the basics of tuberculosis, most of us, we know, we'll go to the recent advances, like how we can diagnose it in an early stage, how we should manage it properly with the awareness and combining together and having a uniformity into the treatment. Basically, it's a very ancient disease, and which is caused by the Mycobacterium tuberculosis. And commonly, the respiratory system, GI system, lymphoreticular systems. So it's a multi-systemic disease. The skin, central nervous system, the musculoskeletal system, and the reproductive system, and the liver. So you name a body part, and it can be involved with, and dated way back, thousands of years back, it has been there. And for a human pathogen with no known environmental reservoir, Mycobacterium tuberculosis has earned the art of survival and has persisted in human communities from antiquity through the modern times. So even in Western countries, US and all, they are so scared. They screen at the airport, and if suspect the person is not allowed to enter, so much it can spread so fast. And over decades, there are studies done. World Health Organization reports a 22% drop in the global tuberculosis mortality from 2000 through the 2015. So the mortality and morbidity has come down, but still it is spreaded. Even in the Indian scenario, the children with tuberculosis are suffering. I remember when used to be so many tuberculosis meningitis, biliary tuberculosis. We don't see such type of cases nowadays because of the BCG vaccination and awareness to pick up in an early stage. But still, it is prevalent and many cases are seen. So we all know it's like one of the mycobacteria which cause and these are the non-sporing, non-mobile, oblivate, aerobic, circulative, catalase negative intracellular bacteria. The organism has several unique features compared to other bacteria, such as the presence of several lipids in the cell wall. The high lipid content of the cell wall is thought to contribute to the following properties of tuberculosis infection. So the resistance to several antibiotics. So that's the problem in tuberculosis. Like halfway treated patients will spread to the other person, and that person will have a multi-resistant organisms, and then the same medications may not apply that. That's why the patient should complete a treatment. Recently, when we had a camp for the human papilloma virus, like to prevent the cervical cancer vaccine camp. And one of the very well-known personality had been to our hospital. And when I was talking to her, she said, like in her childhood, she had a tuberculosis. Again, in between, it was in a dormant stage. And recently, she had developed a cervical tuberculosis, the lymph nodes. And it was so cumbersome last 1.5 years. She's taking a treatment, and in between, she has to loss of weight and so many problems. So this difficulty in staining the gram stain and several other stains, it becomes difficult to diagnose. Ability to survive under extreme conditions such as extreme acidity or alkalinity, low oxygen situation, and intracellular survival within the macrophage. The geographic distribution, most of the parts of the world, only few parts where a lot of efforts have been taken and it has been eradicated. But otherwise, ASEAN, African, Eastern Europe, Latin, Central America, they still have a high burden of tuberculosis. And the other major risk factors, socioeconomic factors, poverty, malnutrition, wars. I will say rather than these, the social etiquettes are important. Even during the COVID, when we had a first press conference in Pune, when one first patient had been from somewhere and from China in Pune, and he had vomitings and all and suspected COVID. So that time we had a press conference by our foundation, and we educated the people that at least use this thing to improve the social etiquettes, because most of the people in India, they go on spitting and all, and so it spreads a lot. So that should be improved. Like these social etiquettes are very important. Then immunosuppressions. Like I remember when I was in a Bombay GT hospital, we used to have a lot of children also with HIV/AIDS during that time, and they used to have a secondary tuberculosis. Chronic immunosuppressive therapies like steroids, monoclonal antibodies, like nephrotic syndrome patients or patients with a repeated blood transfusions, thalassemias, or where the immunocompromised things, a poorly developed immune system. These are rare, like primary immunodeficiency syndromes and all. But even nowadays, considering the number one chronic disease is an allergy, inflammation, or adults with asthma, COPD, they are having a secondary tuberculosis because the Th2 inflammation is increased. Th1 suppression happens. Occupational, like mining, construction workers, pneumoconiosis. Not only that, even I remember when I was studying in Bombay Hospital, the sisters used to be in like a barracks in one room, 6 sisters, or even the meals in Mumbai, we used to hear that. Like they used to stay like a berths in a railway, and they used to have a cross infection. So whenever there is a compact, no ventilation at all, the chances of tuberculosis are there. Then if you see the multi-drug resistant tuberculosis, this refers to tuberculosis with strains of mycobacterium which have developed resistance to the classic anti-tuberculosis medications like rifampicin, isoniazid. TB is especially a problem among patients with HIV/AIDS or chronic immunosuppressives resistant to multiple anti-tuberculosis medications, including at least the two standard anti-tuberculosis medications like rifampicin or isoniazid is required to make a diagnosis of MDR-TB. So basically why it happens, again, the immunocompromised patients, otherwise the person who has infected to the other patient, but he has not completed the proper treatment. So the bacilli become resistant, and then that's why they transfer the resistant virus. 75% of MDR-TB is considered primary MDR-TB caused by infection with MDR-TB pathogens. The remaining 25% are acquired and occur when a patient develops resistance to treatment of tuberculosis. And XDR, like multi-drug resistant, very severe TB, where they are rare cases, but this is very severe type of diagnosis require resistance to at least 4 anti-tuberculosis medications, including the rifampicin, isoniazid, and resistance to any 2 of the newer anti-tuberculosis medications like amikacin or other aminoglycosides. The newer medications implicated are fluoroquinolones like levofloxacin, moxifloxacin, ciprofloxacin, or the injectable second-line aminoglycosides, kanamycin, capivomycin, amikacin. The mechanism of developing multi-drug resistant tuberculosis is similar to the mechanism for developing MDR-TB. And XDR-TB is an uncommon occurrence. As I said, it's less, but still it is very serious because patients don't show any response. Pathophysiology, although usually a lung infection, tuberculosis is a multi-system disease, as I explained in the beginning only. The principal mode of spread is through the inhalation of infected aerosolized droplets. The body's ability to effectively limit or eliminate the infective inoculum is determined by the immune status of the individual, genetic factors, and whether it is primary or secondary exposure to the organ. Even the mother also can transfer the tuberculosis to the fetus. The virulence factors include the high mycolic acid content of the bacteria's outer capsule, which makes phagocytosis to be more difficult for alveolar macrophages. Furthermore, some of the other constituents of the cell wall, such as the cord factor, may directly damage the alveolar macrophages. Several studies have shown that Mycobacterium tuberculosis prevents the formation of an effective phagolysosome. So why we are talking about this? Because of these factors, the patients become the tuberculosis, the bacilli into the patient becomes refractory. Type 4 hypersensitivity and caseating granuloma. Tuberculosis is a classic example of a cell-mediated delayed type 4 hypersensitivity reaction. So we have seen like one fine day the patient starts with having a pleural effusion. The tap detects there is no bacterial infection and all. Serious type of, but it is a hypersensitivity reaction. Then we have to do the pleural biopsy or something, and then the tuberculosis bacilli are picked up. So that is a typical delayed hypersensitivity reaction. By stimulating the immune cells, the helper T lymphocytes, CD4 cells, Mycobacterium tuberculosis induces the recruitment and activation of tissue macrophages. This process is enhanced and sustained by the production of cytokines, especially interferon gamma. And so where there is a type 4 hypersensitivity with the pleural effusion and all, some of the patients become very resistant. I still remember Dr. V.M. Modani used to give a nebulized form of isoniazid and all. It was slightly toxic to some patients, but some of the patients don't used to have a response to the other medications. Then some patients he used to give such type of inhalation form of these medications. The histopathology, the granuloma is the diagnostic histopathological hallmark of tuberculosis. The defining features of the granuloma of tuberculosis are caseation or caseous necrosis is demonstrable as a region of central eosinophilia, multinucleated giant cell. Then on history, most of the patients we have to diagnose. So typically like more than 4 weeks cough, hemoptysis, weight loss, mild low-grade evening rise temperature, night sweats are some of the most common physical findings in pulmonary tuberculosis. Nowadays, the symptoms are also varied. So some of the patients don't show those typical symptoms also. Secondary tuberculosis differs in clinical presentation from primary progressive disease. In secondary disease, tissue reaction and the hypersensitivity are more severe, and the patients usually form cavities in the upper portion of the lungs. So it is mostly seen in the adults and adolescents. Children, they may have a miliary or other body parts also can be involved. So how we have to evaluate? Suppose by the clinical and with the close contact with something or high risk patients, once we identify like it feels like this is maybe a tuberculosis, then we have to do the screening test. So most of the time tuberculosis skin test or TB test or Montus test is very well known for everyone. The Montus reaction following the injection of a dose of PPD, purified protein derivative, is the traditional screening test for exposure to the tuberculosis. Only in children the dose is different and adults it is different. The result is interpreted taking into consider the patient's overall risk of exposure. Patients are classified into 3 groups based on the risk of exposure with 3 corresponding cutoff points. So low risk patients, individuals with minimal probability of exposure, are considered to have a positive Montus test only if there is a very significant neuroduration following the intradermal injection of PPD. The cutoff point for this group of people with minimal risk of exposure is taken to be 15 millimeter. Intermediate risks, the individuals with intermediate probability are considered positive if the duration is greater than 10 millimeter. And high risk, individuals with a high risk of probability of exposure are considered positive if the duration is greater than 5 millimeter. So if the high risk patients, like specifically where the exposure can be more, then the 5 millimeter also can be. The significance of screening is that a positive screening test indicates exposure to tuberculosis and a high chance of developing active tuberculosis in the future. Tuberculosis incidence in patients with positive Montus test averages between 2% to 10% without the treatment. And patients with a positive test should have a chest X-ray as a minimum diagnostic test. In some cases, these patients should have additional tests. So most of the time, once we suspect the tuberculosis and we do the Montus test as a screening, then chest X-ray is mandatory. Not only that patient, suppose it comes as a positive chest X-ray, always screen the family members also. It can be in the dormant phase, and then later on they may have a severe tuberculosis. That is compulsory. And then additional tests means suppose HRCT thorax or some of the patients bronchopulmonary specifically bronchi are involved, then the even the lavage can be done with the bronchoscopy. So there are some additional tests or histopathology for the localized lymph node biopsies, depending on the patient. Confirmatory and diagnostics test, chest X-ray is indicated to rule out and rule in the presence of active disease in all screening test positive cases. Acid fast staining, Gill-Nelson method. Cultures in some patients where we suspect a drug registers. Nuclear amplification and gene-based tests are a future now. And these represent a new generation of diagnostic tools for tuberculosis. Like some specific tests are there. CBNAT test is there. It's very specific and which can identify where, and those tests can be done on the pleural fluid or any other like materials from the other body parts can be used for that. And while treating these patients, the latent tuberculosis, 2020, the latent tuberculosis treatment guidelines include the NTCA and CDC recommended treatment regimes that comprise 3 prepared rifampicin-based regimes and 2 alternative monotherapy regimes with daily isoniazid. These are only recommended for persons infected with Mycobacterium tuberculosis that is presumed to be susceptible to isoniazid or rifampicin. So the patient should be clinically, we should suspect that they will respond to the INH or rifampicin. A regime of 3 months of once weekly INH plus rifampicin is your preferred regime and is strongly recommended for children aged more than 2 years and adults. First line medication group 1, INH, adults 5 mg per kg, 300 mg daily. Rifampicin, children maximum is 10 to 20 mg per kg, up to 600 mg once daily or twice weekly. And then rifabutin. How we should differential diagnosis, because we should not miss the other things also. And it is a great mimic and should be considered in the differential diagnosis in a pneumonia, malignancy, non-tuberculosis mycobacterium, fungal infections, histoplasmosis, sarcoidosis. So depending on the occupational hazards, some of the patients may have a such type of exposure. And so we should not forget also, because these are also increasing nowadays, cancers. Then after the post-COVID, a lot of different type of pneumonia we have seen. Even that's why PPD 23, pneumo 23 vaccines have been introduced in India also. Toxicity and adverse reactions, side effects associated with the most commonly used antitubercular drugs. Most of the time, patients have a severe gastritis, indigestion, loss of appetite. This is very common, weakness and all. Asymptomatic elevation of aminotransferase, 10 to 20% of the cases. So we should always, when the patient is on INH, repeat the liver markers, peripheral neurotoxicity, hypersensitivity. So the vitamin supplementation, B12 or other B complex vitamins. Rifampicin, itching, the pruritus, nausea, vomiting, flu-like symptoms, hepatotoxicity, orange discoloration of bodily fluid. So always tell the patients after the RMP, the patient is on that. So discoloration of the urine is very common, so don't get scared. Side effects associated with the most commonly used antituberculosis drug, rifabutin, neutropenia, uveitis, polyarthralgias, hepatotoxicity. Rifapentin, similar to rifampin. Pyrazinamide, hepatotoxicity, nausea and vomiting, polyarthralgias, 40% of the cases. Acute gouty arthritis, rash and photosensitive dermatitis. Then ethambutol, retrobulbar neuritis. So depending on that, we have to change the medications. Then complications of the disease are very important. Like as I mentioned, previously we used to see a lot of neurotuberculosis and biliary tuberculosis. I have seen many patients in JJ Hospital, in Wadia, or even the Bombay Hospital. But now those cases are reduced, but other complications can be there. The complications are more frequently seen in patients with the risk factors mentioned, like immunocompromised HIV patients and all. Extensive lung destruction, damage to cervical sympathetic ganglia leading to Horner's syndrome, acute respiratory distress syndrome, like somebody has a type 4 pleural effusion or some alveoli collapse, secondary infections, miliary spread, empyema, pneumothorax, systemic amyloidosis. So, considering this is a very age-old disease, but we could not eradicate because of the multiple factors. And so, advances mean it's not only the medications like second generation aminoglycosides or levofloxacillin or linezolid and all. It's basically advances means to make the awareness amongst the people, the seriousness of the disease, not to spit in the public places, use the hygienic things and all. cover the mouth while into the public places. Suppose somebody has a tuberculosis or something, and it should be open. Still, it is a big stigma. People hide the disease. It should not happen. So that awareness should be there. Then the vaccination now, at least BCG vaccination is done everywhere. So it can be a preventable and treatable infectious disease. Having said that, it is still one of the major contributors to morbidity and mortality in developing countries where we are still struggling to provide adequate access to care. Other challenges include lack of awareness, delayed diagnosis, poor accessibility to medication and vaccination, as well as medication adherence. So many of the patients, symptoms are reduced, they stop the treatment. So they don't think they may have again relapse, or they infect to the other person and it becomes a more drug-resistant tuberculosis. Now, direct observed therapies have been there proposed by the WHO, has been very effective in recent years to improve the adherence to treatment in tuberculosis patients. So even most of the patients now have a very good access to this DOTS therapy in government setups, corporation setups. So even nowadays, we don't see tuberculosis patient into the private. Previously, we used to have a lot of private patients also. So now very less because the government is having a very good screening and door-to-door services. So that's a very good thing. And I hope within few years, 2025, we can have a very good control on the disease and whatever the WHO's aims are there, combining together and we all educating to the people, definitely we should be able to eradicate the disease. And that stigma into the community should be reduced. Thank you. Thanks a lot.
Thank you so much, sir, for taking out your precious time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants who have joined this session, sir. Sir, as I can see, sir, in response to that, we have received some question from the participant. If you allow, can I take this
Yes,
question?
please.
The first question is from Dr. Singh. He's asking, can you provide insight into the use of digital healthcare technologies such as mobile health application and telemedicine in tuberculosis care delivery and patient management?
Yes, absolutely. It's my favorite hobby. So that's why 2011 from the Intel, we organized two programs in Pune and one in Kolhapur. So like digital technology should be utilized very well. There are softwares they can be made and the patient's symptoms also can be analyzed, and through that the patient also can enter like the tablets, how they are taking frequently, then analysis of the symptoms. So the symptom score also can be analyzed. So that should be utilized into the community and even to the rural areas so that they can be connected to the uh, where, like suppose in Pune, the center is in Sasun Hospital or some corporation big hospital. The patients in the rural areas, they can also be monitored along with the medical officer at that distant part, like primary health centers and all. So that technology definitely can be utilized because already we are utilizing this digital technology in asthma patients, like even e-spirometers are available. So such type of facilities should be utilized. And that is the future. Definitely it will be useful.
Thank you so much, sir, for sharing your insight in this question, sir. Moving forward, one question is from Dr. Shruti. She's asking, how do advancements in tuberculosis prevention, such as new vaccine and preventive therapies for latent tuberculosis infection (LTBI), contribute to global tuberculosis control efforts?
Yes, I think I still remember even the Serum Institute was having a newer BCG, the modified BCG. So those vaccines definitely will play to have a more efficacy because previously the immunity level was 0 to 85% after the BCG vaccination. So some of the patients may not have a antibodies for that. So the newer vaccines like modified BCG and all will definitely help to improve the higher titers against this infection, and so that the patients will definitely help like a hepatitis B or something. So those future therapies will definitely help. Again, the right diagnosis and the proper diagnosis in an early stage and the selection of the good anti-tuberculosis medications, which will have a targeted therapies, like specifically cervical lymphadenopathy or neurotuberculosis patients and all. The medications don't reach that effectively, or pleural effusion and where the involvement is there. So those patients are resistant. So there, these medications will have a good efficacy. So definitely that is a future and that will help the patients.
Thank you so much, sir, for sharing your insight on this question once again. We will be taking one last question, sir. Can you discuss the role of multidisciplinary care teams and collaboration between healthcare providers, public health agencies, and community organizations in tuberculosis prevention and control efforts?
Yes, already it is happening. Even the government agencies, they are having a tie-up with some of the NGOs to help to go to door, analyze the patients and all. And we are having a tie-up with private practitioners like us. And we have a regularly in Pune, I remember Pune Doctors Association and other associations also. And the WHO's team, and along with the government hospital teams, like chase departments and all, they are having a good time, and we are having a education updates what are happening on these things, and that way definitely it will help. And this should be reached to the slums, specifically the roadside people and all, immunocompromised people, then some high risk areas like red light areas and all. There more work should be utilized so that the spread can be arrested. So that is very helpful or useful.
Thank you so much, sir, once again for explaining this question on behalf of the technology. Sir, as I can see, sir, there is no more question from the participants. With all your permission, shall we conclude this session for today?
Okay. So thanks
Thank you.
everyone for attending and having a questions. So whatever the best possible, I tried my best to enlighten on the subject, and I feel very fortunate to interact with all. Thank you very much, and thank you IGCP for giving the platform. Thanks.
Welcome, sir. And I can see, sir, one comment Dr. Shruti is writing. Thank you so much. Wonderful presentation.
Thank you.
And take care, sir, and hope to see you again with different topic in future also.